is Dr. Sammy Noumbissi. All right, Dr. Noumbissi obtained his doctorate of dental surgery from Howard University in Washington, D.C. He was then selected to attend Loma Linda University graduate program in implant dentistry, where he received 3 years of formal training in dental implantology, which culminated with a certificate in implant dentistry and a Master of Science degree in implant surgery. He is a researcher, author, and has published abstracts and articles on ceramic implants in peer-reviewed dental journals. He lectures nationally and internationally, and is the current and founding president of the International Academy of Ceramic Implantology, which is an independent association and education provider exclusively focused on metal-free and ceramic implantology. Dr. Noumbissi has been practicing and educating dentists in metal-free implantology since 2009. His practice and the academy are both located in Silver Spring, Maryland. All right. So without further ado, Dr. Noumbissi.
All right. Good afternoon. Thanks for taking time out of this very nice, rich program. First, let's put the disclaimers out of the way. I do not have any financial interest of a product in my talk with any companies offering grant monies for discontinued dental and medical education program. In short, I paid my way to the podium. How about that? But the right way. Okay, so thanks for coming. Is it possible at all? It depends on the video, guys. If we can dim the lights a little bit, if they don't have to. But if it's possible, let's do that. Otherwise, I'm okay. No, the spots you need for the video, right? I'm talking about the big ones. But if that doesn't work, that's fine. I don't have a problem. Okay, so the topic of my presentation this afternoon is about ceramic implants. I've been talking about this for 10 years. So usually when my name is said somewhere, they always want to talk about ceramic implants. So that's what I do best. That's what I enjoy doing. And today I want to talk a little bit about the background, the rationale, and share with you my 10 years of clinical experience. It's amazing how time goes by. I just ran into a friend, Dr. Luer, in the hallway, and he says, "Oh, you taught me ceramic implants in Kansas 10 years ago." It's unbelievable. So, but it's nice, it's rewarding. So, I'm involved, like I was introduced, in a lot of things. A little bit of, I like organized dentistry, especially in terms of implantology. As you can see, I've always been involved with ceramics. I founded the Ceramic Implantology Association, which had its 8th meeting in February in Tampa. We have a Zirconia now implant research group where we really focus, we do research, clinical and experimental research, to put a little bit of tidiness in the literature about ceramic implants. There's a lot of stuff out there. There's a lot of clinical reports. There's tons of opinions, but it's not structured like it is with titanium. And titanium has been around, what, 50, 60 years? Ceramic implants started in people's garages and timidly came around, and it's really now exploding. So there's a need for research. And most recently, one of the largest ceramic societies in the world, the American Ceramic Societies, endorsed us as one of their representatives when it comes to ceramics in dental implantology. So we're going to even have a joint meeting with them in Toronto in the fall. And I've also recently got involved with the Clean Implant Foundation. The Clean Implant Foundation is out of Germany, where we analyze implants that are on the market for their cleanliness. You won't believe how contaminated some implants that you buy, titanium or ceramic, can be because of the packaging. We have some implants that come in sterilization bags. We have some implants that come in nicely packaged plastic containers, or some in glass containers. Some are blasted, some are milled, some are coated, and they come, and the manufacturing process can also contaminate the surface of an implant. So I've gotten involved with this. It's very interesting. And of course, I teach all over the world. This is the University of Chieti in Italy, where I'm a guest professor. So let's get to the core of things. Dental implants. What are dental implants? Permanently implantable biomaterial. It can be made of many things: titanium, cobalt chromium, zirconia, titanium alloys. Okay, we insert them in the bone. They provide a base for various prosthetic schemes, full arches, singles, bridges, whatnot. We expect them to integrate well with the surrounding soft and hard tissue. So if you place an implant in somebody, you essentially want that implant to disappear, to become like a tooth and not be identifiable as an implant. Okay? But most importantly is that you want to, this implant ideally should not interfere with the surrounding biology or the host's health. And that's where the beginning of the problem starts. That's where the problem starts. Is that are all implants completely inert and totally do not affect the host? So we're going to talk about that. So now, implantable materials have different categories. So the material that you use for a retina implant or even for a knee implant is not exactly the same that the one you use for a dental implant. Okay? So how are they classified? Is first of all the chemical composition of the material, then the function or part or organ that that implant is supposed to replace. Okay, so the material, the PEEK material that you use for a valve is not the same PEEK you use for dentistry. And even within dentistry, there's different grades of PEEK for different applications. So that's very important. But most importantly is the biological response. How is that individual going to respond to that implant, whatever that implant is? So there's 3 criteria to assess implant success. Okay, from top to bottom, we look at occlusion and aesthetics. Does it look nice? Does it function well? Then we look at what happens at the gum, at the gingival level. Is the soft tissue affected? Is it red? Does it bleed all the time? Is the implant well integrated? Is the bone and have the bone and the implant accepted each other, so to speak? But the one thing that's never really talked enough is, does that implant, whether it's ceramic or titanium or PEEK, because PEEK implant exists, we just don't have them in the United States, but they exist, do they trigger what they all in an immunological response? And if they do, what type of response that is? Is it a good inflammation or a bad inflammation? Okay, things like that. So, and then we look at the implant stability. Is the implant stable physically? Is it compatible to the tissue? And again, does it cause any type of disruption to the immune system? So, having said that, and taking those things into consideration, we find that we have today on the market in the United States, we have 2 categories of implants. We have the metal implants and the metal-free implants. Metal-free meaning ceramic, for now. So, the metal implants are generally the same. They're titanium alloys today. Pure titanium implants have virtually disappeared from the market. They're mostly all alloyed. And they're alloyed with aluminum and vanadium. And this is there's no better group than this one to understand sometimes what problems aluminum can cause to one's health. But we'll get to that a little bit later. So, and then we have all these varieties of ceramics. When I started ceramic implants, there was only one, YTZP. Hot isostatic press YTZP, that's all there was in the US market. And in the last few years, we see ATZ, ZTA, we see all kinds of formulations, all with the objective to get to a material that's going to behave very closely to a tooth, or that's going to be in unison, function in unison with bone in terms of physical properties and things like that. However, all implants have a biological effect. Whether it's ceramic or metals implant, they have some type of biological effect. And the effects can range from cytotoxicity to carcinogenicity. There's some type of effect. There's always going to be some degree of an inflammatory response or some type of inflammatory response to that implant. The question is, to what point? Okay? So based on those considerations, we know there's always going to be some type of there are always some types of complications. What we strive for is that they don't happen all the time, or very little. But if you look at the literature now, there's a lot of talk about peri-implantitis. And the American Academy of Periodontology, at their last meeting for the first time, pointed the finger at the implant material as a cause of peri-implantitis. It was always the buds. It was always the occlusion that wasn't right. It was always the implant that was not placed in enough, that was placed in insufficient bone. And now we gradually start to realize that the material with which the implant is made can be the problem. And we're going to go over that. So you look at literature, 9 to 14 years, 48% chance of perimucositis. 5 to 10 years, 28, 56% chance of peri-implantitis. A lot of people say, oh, I do so many implants per year, I never had any problems. That's not true. Their patients tend to come to my office to have the implants removed. For whatever reason, they want them removed. Or they come, even my own implants, I did titanium implants for 10 years, a lot of them, before I changed, and they come back with bone loss. Even when they're not failing. Actually, we found a nice name for that, ailing or surviving. And there's more and more reports of patients' response to titanium and its alloys. So it's a problem that's now being recognized a lot. A few years back, when I told a colleague that somebody can have an immunological problem with titanium, they thought I was crazy. And although it's well documented for 20 years, orthopedics has known this for a long time. Even in dental, there's some old reports, but it's not taught anywhere. So the bioceramics, just to get that out of the way, it's anything that's a bioceramic, it's a material that's crystal in structure, that's designed to be placed in the body. And the bioceramic can be an implant itself, as we know it, physical, screw-shaped, or whatever, but it's also graft materials. You have materials like beta-tricalcium phosphate, hydroxyapatite. Those are bioceramics. So if you're grafting with synthetic bone, like Curacao and others that I saw there, you're using a bioceramic. If you're placing a zirconia implant, you're placing a bioceramic implant. And they have very interesting, nice properties. As far as the implant, they don't undergo certain changes that titanium implants go, such as corrosion, release of ions, material fatigue. They have other types of problems, but not those. So the question comes, even after I give talks like this for an hour or two, at the end of the day, somebody comes to me and says, well, is zirconia bioceramic or metal? Yeah, after we talk for 2 hours and then somebody else. So let's look at the fundamentals. Chemistry 101, right? If you look over there, titanium and zirconium, not zirconia, titanium and zirconium are in the same area of the table of elements. And the elements that are here are what you call transitional metals. So these are metals that under certain circumstances, certain conditions, industrial conditions, you can make them transition from a metal to a ceramic, to a crystal. It's like I always joke with people. Do you eat salt? Yes. What is salt made of? Sodium chloride. What is sodium alone? A metal. When it's mixed with chloride, what is it? A salt. It's a ceramic. Sometimes that helps people elastify, make their understanding of that a little more elastic. So there's certain materials that when they get combined, they can become ceramics. Zirconium with oxygen, zirconia. Aluminium with oxygen, alumina. It transitions from metal to ceramic. So, zirconium, metal which is mined from the earth. Zirconia is a crystalline oxide of zirconium. And zirconium dioxide is also known as zirconia. I prefer not to use this terminology because it's confusing. Because most of us get lazy and leave out the dioxide and say, I'm doing zirconium implants. There's no such thing as a zirconium implant. It doesn't exist. The closest to it is a rock-solid titanium zirconium implant from Straumann. Okay, so if you say you're placing ceramic implants, use this word instead. It confuses your colleagues less and your patients less. Because some patients, I had a patient say, well, I went somewhere, they told me a zirconium implant. Isn't zirconium a metal? What's the difference? Is it just white? So use the right terms, it just makes things a lot easier. So how do we go from zirconium to zirconia? I'm going to go through this a little faster. Again, it's an oxygen, zirconium, you get zirconium dioxide, which is also called zirconia. Okay? Then, usually, most implants, this is a generic description, how they're made, you always have ceramic powders. They always start with powders. So these powders are a mixture of these three ceramics: zirconia, alumina, and yttria. Yttria is more of a stabilizer. Zirconia gives it a little bit of flexural strength, alumina, and then zirconia. But zirconia is always in the greatest numbers. They get all mixed together, compacted, sintered, and on the hot isostatic press, you get these blocks, similar to your CEREC blocks that you have in the office. Similar, not exactly identical. And then those blocks get milled into different types of implants, different brands of implants, and then in some cases they get resintered after the milling. Some get sintered before and then milled. It depends on the company. It's just every company has a protocol. So what happened historically? How did we come to all this? So the transition was initially subgingival. We started with implants like that, the brand mark implants. Late 60s, mid 50s, that's what it was. Then as time went by, in the name of increasing osseointegration, and maybe somebody was aware that these things had a corrosion problem, we started coating these implants with HA. But what's HA? HA is a bioceramic. So I always tell people who place HA-coated implants, you're placing a metal implant coated in ceramic. So why are you afraid of ceramic implants? Well, they say ceramic implants will break. Well, that's not, we'll get to that. So again, you can see over time, subgingivally, there were the changes. So implants started to get coated in the 80s with ceramics, with bioceramics. Then supragingivally, we started to remember that we were dealing with teeth. So we tried to make the implants look a little better, closer to teeth. Then we started making abutments that look a little more like a tooth, but everything was still metal. Then we said, you know, the metal is going to be under the gum, but we have a problem with the grayness showing through the soft tissue. Why don't we start making abutments in ceramic? Sorry. So we start doing that. Now, what's the problem with this? You're connecting two materials with two different physical properties, and you ask them to function in unison. Guess what? Tons of fractures here. It's not the same. This doesn't flex the same way that flexes. So when we started noticing that, we said, okay, we're going to put a metal interface. So now the interface is going to be metal to metal, and the ceramic is going to be at the top, so we avoid these fractures here. It worked a lot better, tie-based, that's correct. And that's what you see a lot available now. And by and large, it works very well. Then, it got into the material itself. So we started having a lot of different types of materials. I don't know if anybody in this room is familiar with Driscoll, but Driscoll wrote the first papers, one of the founders of Bicon implants. Actually, this is an original Bicon implant. In 1975, Bicon already started playing with ceramic implants. 75. But if you notice all these implants here, especially up to here, up to 1980, they were made of 100% aluminum oxide. So they were monocrystalline. And aluminum oxide is very difficult, is very rigid. That's why the original ceramic implants had a lot of fractures. Okay? And they also even tried in those days to make 100% zirconia implants, where zirconia has a very serious problem with moisture. And we know the mouth is very wet. That's how you start to see these implants that have ATZ, ZTA. That's where that is coming from. So anyway, up to here, the tubing and implant, which was the one that gave ceramic implants a really, really bad name, because they always fractured there at the neck for obvious reasons. That's what gave a bad name to ceramic implants. The Sapphire from Kyocera in Japan was a glassy implant which integrated very poorly and failed most of the time. Okay, so later we have other implants that start coming, they become polycrystalline, they all come in one piece, and that's how things start to take shape and get to where we are today. Now things have moved very fast. Look what has happened between here and there. Now, when this came out, I was really excited. I was very happy. Then this comes out. Then that comes out, and I'm like, what's going on? We're repeating the same stupid mistakes. We're matching metal screws with ceramics. We're having these abutments here into ceramic. I mean, really? So this, to me, it bothers me, really. It doesn't make sense. Okay, I told these guys, I said, when you have another solution, I'll use it, but I'm not touching this. It just doesn't make sense. This is a carbon fiber screw from Xeramex, which makes a lot more sense. It has a little bit, and it's not prone to fracture like metal screws. So these are things. So what I'm trying to say here is that things are moving now a lot faster than they did when we started, and there's going to be a lot of nonsensical things that are going to come on the market. And you have to, for once, because we dentists are notorious for just going after new things. I've been guilty of it. I'm guilty of it sometimes. You have to just stop and think, why are you doing this? And how are you going to explain to your patient that that metal screw in there is never going to be exposed to everything else around? It's impossible. We all know the pump effect. We all know that when implants are in function, there's leakage. There is. Take out an old implant and smell it. You don't even need to smell it. Just stand over, you smell the smell that comes out of it. Because there's leakage, there's bacteria in there. Anyway, so there's been an evolution. We've gone to solutions like this to solutions like that. And you have a choice. There's still some folks doing amalgams out there. So if you want to still do titanium, you're not doing anything criminal. You're just not aware, or at least by the time you leave this room, you'll be aware of what can happen around them, and if it's something you still want to do. So I'm not here to say anybody is bad because they're doing titanium implants. I did thousands of them before I switched. So the question now is, why is there this shift? Why is it that Straumann all of a sudden has a ceramic implant? Nobel has a ceramic implant. Camlog has a ceramic implant. Southern Implant is going to be having one soon. I mean, all these big players, the two biggest players in the world have a ceramic implant on the market now. And if these guys get into something, it's because they know there's something for them in it too. They're corporations. They don't go to please people. They go to things that are viable. And any businessman will do the same. So let's look at the composition of titanium first of all. Like I said, 90% aluminum, titanium, 6% aluminum, 4% vanadium. Now, what we're told, or have always been taught, is that titanium is biocompatible. Now we have to ask ourselves, is it biocompatible or biotolerated? But that's a debate that we can have. That it can develop an oxide layer. Studies are now showing that in the process of inserting that implant, that oxide layer usually gets wiped off the implant. We were always taught that titanium is one of these materials that never corrodes. There's tons of literature, old and new, that shows that there's a corrosion problem with titanium. So, if you look at the composition of titanium, you'll find that there's a whole host of other metals that are not mentioned in the general composition that are there, such as nickel. It's very little, but it's there. And I've had patients that have had problems with titanium implants, and when they were tested, nickel was the issue. Although minute, and I'll show you some cases. So the biggest concern with metals in the oral cavity is corrosion. It's a wet environment. We're coupling different metals of different compositions, and you will have some type of electrical activity between those materials. It's just like the fillings. They told you not to put a gold crown against an amalgam because you're going to cause galvanism. So why do you connect an abutment made of a metal alloy that you don't even know the composition to an implant, connecting them with another screw that's a third type of metal? All this in a very nice electrolyte called saliva. So we have certain types of corrosions on titanium implants, on metal implants. We have galvanic corrosion. We have corrosion that stems from fatigue and stress, from wear, from bacteria. There's such a thing called bacterial corrosion. And there's also fluoride-induced corrosion, good old fluoride, right? And all these phenomena are electrochemical in nature. So let's look at galvanic corrosion to start with. It's electrochemistry. Is a loss of metallic ions from the surface of the metal to the surrounding environment. Okay? So it's an anodic event with release of metal ions. And who is the anode in that case? Is the implant. So the implant, when it gets corroded, gives away some of its components to the peri-implant tissue. There was a study done at Loma Linda on dogs where 10 days after placement of titanium implants in dogs' jaws, they were able to find aluminum and titanium in the lymphatics of the neck of the dog. Okay? So what that means is it doesn't go in there and just sits there and is inert and does nothing. It has to survive the environment. So, just a schematic. You have the abutment, you have the screw inside, you have the implant, you couple all them up. They're mostly dissimilar alloys. The fluids get involved, and you start to get release of ions into the bone and to the soft tissue. And then you get soft tissue discoloration, or you get peri-implantitis, an inflammation of the surrounding bone of the implant. That's why the AAP started looking at the implant itself as a source of as a potential cause of peri-implantitis. And other organizations. This is out of my office. Looks like what? A rusty nail, right? That's my patient. My patient, well, this is the same patient. But this is a situation where the crown got loose, and for a long time, she kind of had it in her mouth and didn't come in, and finally when it was super loose, she comes in. But again, that's corrosion right there. That's where most of the corrosion on implants happens, at the abutment-implant connection. Because of what? The corrosion, the galvanism, yes, but also the fretting, the fatigue, the movement, the scratching, everything that happens in that area because of movement and function. This is a situation where we had done a full arch, and this was cemented over that. And we had to remove it because some piece of popcorn or whatever got stuck in between, and she couldn't take it off with a water pick, so we had to take it off, and look at what we saw in there. This happens. I used to see stuff like that many years ago and just wipe it off and put a new screw and put back the crown back. And now I understand what it was. It was corrosion. I said, this looks like it's rusted. Oh, maybe it's just old food or whatever that's there, but that's not the case. It's corrosion. So the mechanical corrosion, that's what I was talking about. The mechanical corrosion usually occurs here because that's where things move. When the patient chews and uses that tooth, things move. There's a lot of stress here, a lot of friction here, a lot of scratching. And there's a lot of pumping in and out of old saliva and bacteria every here. So now this area becomes acidic. And when it becomes acidic, it attacks the implant and the abutment and creates even more corrosion. Because acidity causes breakdowns, causes corrosion also. Here's a good schematic just to illustrate that. That was the crown that went in there. This is the part that was rubbing onto that part. And that's the area where you have the highest amount of corrosion on implants. Same thing, subgingivally. This is not my picture, but Look at that. You take an implant out, look what's left in the bone. Now, immunologically, what happens? When that corrosion happens, the ions get released from the implant. What does the body do? TNF-alpha, inflammatory response. We got to get those metal particles out of there. So they send a lot of, how do you call those, phagocytes? They send a lot of, well, there's a rise in TNF-alpha, the macrophages come in and try to eat up all those metal particles. The problem is that they cannot digest it, so they send more and more and more, and the inflammation grows. And then you start having situations like that, where this bone tries to repair itself vigorously, and now you start having that fatty bone over there, and the peri-implantitis process starts. Actually, this is a slide from Dr. Lechner, from Germany, from Munich. And what happens there is that you have an inflammatory cascade that starts. So you have the pro-inflammatory cytokines, the inflammatory cells, and when that happens, you have an increase in osteoclastic activity. So if the osteoclasts get more busy than the osteoblasts, they're breaking the bone down as a result of an inflammatory response. So that's where your peri-implantitis comes from. But one of the reasons you can have peri-implantitis. Okay? So essentially this is what happens. The implant is placed, ions get released, the macrophages come in, try to digest, and they come in greater and greater numbers. Bone gets lost because the area is so inflamed, and then you start having, as a result of that, all that inflammatory cascade, you get a rise in rankles, and you have what is called now a pathologic inflammation, which results in peri-implant bone loss. So soft tissue response. The soft tissue response is usually around ceramics is a lot better than around metals. Okay. You tend to see that you have more keratinized tissue, you get better microcirculation into the tissue. That has been documented. You have less leukocytes in the epithelial cells. It's just healthier tissue around zirconia, as you can see in this picture. This implant here is not failing. It's not loose. It doesn't hurt. But look at the tissue here compared to here. Or look at it compared to here. This you will see all the time, especially with one-piece ceramic implants. A lot of people don't like one-piece implants. I love one-piece implants if I can place them all the time. The problem is that they're hard to place because it's like a tooth. It's like a prep tooth. There's no subgingival connection, and everything happens supragingivally in terms of prosthetics. But even with a two-piece, you still see very nice tissue like that, just because of the nature of the material. It doesn't accumulate bacteria. It accumulates very little plaque, therefore a lot less bacteria. Therefore, there's also a much lesser inflammatory activity here compared to that. And I can give you an example of a case I did in my office many years ago. It was a two-piece ceramic implant with a cemented abutment. And at the time of delivery, look at the black triangle there. And as time goes by, it closes itself without any intervention. That's something that if you have patients who are patient enough to wait for that to happen, you will see it happen spontaneously, sometimes a little faster than 2 years, but you tend to see that soft tissue around ceramic abutments or ceramic implants tends to fill in by itself without any graft or stuff like that, because the material is just so friendly. And it's not charged, it's not electrically charged. So it attracts less plaque, less bacteria, and is always pretty much healthy. Now, like I was saying, why is there less bacteria on zirconia than titanium? It's all about surface energy. Think about your car. When you get it waxed, the water beads off of it. When it's dirty, it kind of pulls on it. It's a similar concept with bacteria and surface energy. If the surface energy is low, plaque just can't stay there. Therefore, there's not going to be enough in habitat for the bacteria to live there. But if you have a surface that tends to be a little rough, because highly polished titanium is never as smooth as a polished ceramic. So and plus it's charged. It has charges in it. So it's always going to attract and retain bacteria and plaque. That's the reason why. And there was a study done by Rasperini, and Scarano replicated also. They found that when you do some cultures after 14 days on titanium implants versus ceramic, you tend to have a more virulent species on the titanium. So no wonder why you have more inflammation around metal parts and metal implants. And you have more cocoids around ceramics. Now, osseointegration of zirconia, how does that happen? Well, first of all, you have to understand, zirconia implants do not have any coatings. It's the implant itself that's roughened or treated, and the bone grows into your implant or onto the surface of that implant. Okay? So there's many techniques of roughening implant surfaces. You have what you call subtractive techniques, where you blast the implant and you roughen it by subtracting some parts of it off of its surface. And then you have additive techniques, which do not apply to ceramic implants, where you do the coating. So that doesn't apply to ceramics. Okay? So, let's skip that. So when you have integration of implants, for example, you have a zirconium oxide or a zirconia implant compared to an HA-coated titanium implant, you have an interface between the implant and the bone. That's why sometimes you see implants fail and come out. The HA stays in the bone. The metal implant comes out because the bone was integrated to the HA, but the HA got separated from the implant over time. That happens. Whereas with zirconia, you have a direct integration of the bone into the implant itself. It doesn't mean ceramic implants don't fail. That doesn't what it means. It just means that it's a different process of osseointegration, and they both work. So the osseointegration of zirconia is unique in that there's no intermediate material between the implant and the bone. Okay? And the process by which implant and bone interact is one of a direct bone-to-implant material contact and anchorage. And the success rate of ceramic implants are as good and comparable to titanium. So, before we go to clinical cases, based on what we talked about, metal, ceramic, can lose a titanium oxide layer, not subjected to corrosion, vulnerable to corrosion, no ion release, galvanic activity, not electrically charged, low bacterial colonization, higher bacteria, higher plaque, back and forth, high surface energy, low surface energy. When I look at all these factors, I have no choice to call zirconia titanium biotolerated. I no longer consider titanium a biocompatible material, at least for the dental implant application. Because it corrodes, it releases ions, it retains plaque, it's electrically active. So in my book, that's a biocompatible material now, until something else comes up in 50 years, 20 years. Things happen a lot faster these days. So let's go into clinical cases. I'll go a little fast. So this is the early days. James, you remember that? Those implants that look like screws. That's what they looked like. There was no shape, whatever, but they really worked. So anyway, this is one of maybe my first or second case, almost 10 years ago almost. And I placed the implant. Now, this implant is two-piece. I want to draw attention to a couple things. Some of you probably already noticed the problems. This implant is too close to that tooth, right? You know why that happened? because I was coming from bone-level titanium implants. I'd done a lot of them with a lot of success. I was a little cocky. I didn't pay attention to details, and I forgot that these implants have 2 diameters. There's a diameter here, and there's a diameter here. And my brain only worked with that diameter down there, and forgot about this diameter there in the restorative platform. And this is what ended up happening. So down there, things are fine, up to here. But from here and there, I have the second diameter that now is invading the space of the adjacent tooth. I'm showing this because there's still a lot of good one-piece ceramic implants out there. I still use one piece occasionally, actually pretty often sometimes. And I don't want you to make that kind of mistake, because it will happen, especially when you go from one type of concept to the other. So anyway, that was a mistake. The implant was placed. I decided not to do anything about it and see what happens. This is not the same case. This is just an intermediate picture to show that this implant, you're able to reduce. You can prep it. That's the problem I have with the Strawman. The one piece, you cannot prep it, but this one you can prep and create some space and send the patient home either with a temporary appliance or protective appliance. In this case, again, I was in the midst of my uber confidence with implants. I went ahead and I immediately temporized it. I made a crown, I put it there, temporary crown, took it out of occlusion. To make a long story short, everything went well. I did not lose soft tissue here. That would have been a death sentence in other scenarios, but the soft tissue remained. And I think it did solely because of the type of material that I was using there, that was involved here, because it was very close. So an impression was made later. Models, just like teeth. This was a full contour Brock-Zier. Today that crown looks so ugly. Looks like a toilet bowl. Has no personality, no translucency. But at the time, that's what I knew best. That was in 2012. 2011, actually. 2010. So what I used to do then, which I don't do a lot, I used to be very concerned about the crown coming off. So I would go and do a decontamination of the zirconia and then do a priming, both of the abutment and the intaglio of the crown, before I did cementation. You cannot cement zirconia with zinc phosphate cement. It's not going to work, because the phosphates are going to go on the free bonds on the surface of the abutment, and it's going to prevent bonding. You don't cement zirconia crowns to zirconia, you bond them. It's adhesive dentistry then. So you're going to always use, so now what do? I seldomly do this. I just cement with a glass ionomer cement, and they stick. But in the beginning, when I didn't know much, I just went by the book. I did a lot of literature, so I did a prime, a decontamination with IvoClean, and then a prime with Z-Prime, and I got also very good results. Anyway, the crown was cemented, and this is the results over the years. Actually, the other day, she came back, and the crown had come off. As a matter of fact, the crown de-cemented, and I re-cemented it, and this is where it was. So, next case. And this is where things have really evolved pretty well. When I started ceramic implants, the smallest ceramic implant was 3.6 millimeters. Much bigger than the average mandibular central or lateral incisor. So we're also very limited as to the case we could do. And now we have ceramic implants, two-piece ceramic implants as small as 3.3 millimeters. So you see, the range of applications of these implants is starting to broaden. So now we can replace mandibular teeth that have problems. So this one had resorption. The endodontist can condemn the tooth, which is good. And we go into surgery, we extract the tooth, osteotomy, mean, it's a very tight space. I did not even bother to use a guide. I said, just use your brain. And I just brain-guided surgery, like Scott Gans would say. And then, so I just go and place the implant, finish by hand, and gave this patient an S6 appliance and sent him back to his dentist. I've not seen him. He came from California, as a matter of fact. But anyway, he stayed around long enough that I was able to see how the soft tissue healed around it. And then he went back to have it restored. But if you look at the post-surgery x-rays, that's basically what we had. A very tight space, but we were able to get the implant in there. There's another one, very similar, but this involves two. So here we have the tooth that was already missing for a while, and one that needs to be extracted. It was as a result of ortho. He had ortho for years. Teeth were moved back and forth, and this one was very mobile. So he had the option of getting one implant and doing a cantilever, or doing two implants. He wanted to have two. Again, we had a lot of space challenges, as you can see on the x-ray here. So this had to go, and we're going to place two implants there. So we're removing this and try to get two implants in there. Pretty challenging. But we went ahead, did some scans, assessed the space, assessed the width, the height, extract the tooth, osteotomies. Here, in this case, is one of the rarest cases, and I don't advocate it a lot, of using osteocondensation drills, where you reverse drill with a lot of irrigation, and you do what is called an osteocondensation. I don't like that too much anymore. You have to be careful where you use it, because the failure rate of implants kind of increases with that, and I had to discover that the hard way myself. Because when you think about it, when you drill in reverse, and you remove the bone and you pack it in the walls, yes, you create a very good primary stability of the implant at the time of insertion. However, bone has to heal. There's a turnover that has to happen. So when you place that implant in, it's tight, but it's tight in compacted bone. So when that bone breaks down to allow new bone to form, that lag time makes the implant loose, allows the implant to loosen. And you have a higher rate of failures. So I don't use that a lot too much anymore, except if the bone is really soft in the posterior maxilla. And even then, I just stick to the manufacturer drills, and I either insert the implants with a slightly higher torque to get my primary stability. But that's what we did here. That's a reverse drilling. So lots of irrigation, and we drill in reverse. And you know when you drill, usually the bone comes out in your suction. Here, when you drill, the bone gets compacted, and you get a nice, tight osteotomy. But it's not always an ideal thing to do. So the implants get inserted. So it's very tight. We're able to get two in there. Patient heals for a few weeks. Now we're ready for impressions. Look at that. And we made some custom abutments. One thing you have to be careful, especially with this system, I like to share, give you little nuggets. You have to really pay attention to the size of your tooth before you choose to use that, because the way this screw is made, it can only be so small. Therefore, it takes a lot of occlusal space. So if your tooth is too small, then don't do it. Because now you're going to have a very large tooth because you need to accommodate that screw. So it's nice to have the small body implant. It's great because now we have more applications, but you have to pay attention to other details to make sure that the crown is not too big, that the crown that you're going to make is not too big, that it no longer looks like a central lateral incisor. So these are little details. And that was the final product. Very difficult case, but that's what we got. Maxilla, immediate placement. As you can see, this implant has more aggressive threads, like a wood screw. And they tend to have a good primary stability, but you also have to be careful how you use it because of those aggressive threads, sometimes you will follow the path of the softest bone. And sometimes go in directions that you don't want it to go. But anyway, this case is pretty interesting. This guy comes in, cervical decay on most of the 6 anterior teeth. We can see here on the sagittal cut that is pretty deep. He doesn't want root canals. He'd rather have them removed, or if we could do a crown on them. I said, well, by the time we prep and all that, we might get very deep and hit the nerve, and you will need a root canal. Well, I don't want to do that. Take the tooth out. This is what it looks like clinically. The battery is dying. And then we go into surgery. We place the implants. We prep the teeth. And we put him in an immediate temporary. So that's right after surgery, and that's a few weeks. But this is not cemented directly on the implant. It's just kind of hollow because I have 2 teeth on either side to support that bridge. So this is not loaded. 8 and 9 are not loaded. It's just there like a facing, like a veneer. Post-surgery x-rays. 8 and 9. In the intermediate prosthetics, you can see the soft tissue dying back a little bit, but that's not a concern. We have enough papilla there. And we have the permanent prosthetics the day of delivery and a few days later. And the soft tissue continues to adapt itself very nicely to maxillary molar. 1-piece implant. As you can see, the soft tissue is here. The implant is ready to be restored. My margins are very clear, no problem. So we go and we restore. Now note, the patient has class 5 fillings here, but she goes home over the weekend and calls me and says she doesn't like that. She doesn't like the margin of the ceramic implant, which looks just like her fillings here. But so they say the client is king, right? So we just redo the crown. What I like with this implant, at the time I was using it, is that you can prep it. So I was able to drop the margin, okay, reimpress, and go from here to there. She was happy, and her husband came, and we did 4 more implants. So it was worth it, right? So, another premolar case. This is a little bit different because it's not immediate placement. I did how it's done. Take the tooth out, clean, graft, and all and whatnot. So that's what it looked like. So we extract it, graft it, allow it to heal, had a nice healed ridge. Now it's very easy to place an implant there. We go back to surgery, we place a 1-piece implant, we give him an S6 appliance. And then later, we have a PFZ crown, a porcelain fused to zirconia crown, and we cement it. And we have pretty good results. Another case, posterior maxilla, 2-piece implant. We did a 1-piece here, and then here we did 2-piece here. Looks like the projector is dying or what. So, those are the x-rays. The implants were placed, ready to be restored. Again, same concept. Cement the abutments. I don't use these anymore, but that's all we had then. So you cement these into the implant. This is a 1-piece. You can see I also prepped the margin here, having learned my lesson from the other case. impressions, crowns delivered. Remember, that's the case I just showed with the tissue changing. And that's what happened over time. From that triangle all the way to the area resolving itself. Now let's step it up a little bit. Full mouths. This lady comes in like that, partial, full dentures. She's had that for many years. And she's had enough. She wants to change it. So this is what she's wearing. So we go in, we treatment plan and everything. We decide that the last is better to rebuild everything. We place 6 implants in the maxilla and 5 on the mandible. However, these are one-piece implants. This is in my early days of ceramic implants. So I had to convince her to accept that I put some temporary mini metal implants to support the denture. Okay? So we did, that's why those are there. It was just to hold the denture so that the denture doesn't stress the implants prematurely. And on the lower, we had a lower denture with a soft reline. So we proceed the same way we proceed all the time. It's like making dentures, mount everything, try-ins, impressions, digital design. We cut back on the buckle because we're going to put some porcelain on the buckle in the front 6 teeth to make it look nicer. Same thing on the lower, try-in of the framework, cementation, and we took her from here to there, and this is what she looks like. Vanadium allergy. We know there's vanadium in implants. Patient shows up. She had implants placed at Hopkins, not far from me. All kinds of tests, nothing works. So we test her, we do a ELISA test. Positive for vanadium. We agree we're going to get the implants out. So we take them out. We place the first 4. This was a very tough case too because I had to split the ridge here to place the implant there because it was so narrow. So we placed the first set, allow it to heal, and came back a few months later and placed the other 2. Connected the abutments, put her in a temporary bridge, fixed, and had her go around like this. I know this is ugly, but we had her wear this for a while because during the time that she was healing, she refused to wear anything. She says, I'm not going to wear a denture, I'm just going to go like that until I heal. So we did that. And then at the end, that's the bridge. Porcelain fused to zirconia, cemented. So we took her from here to there. And we retested her after the implants were removed. And the values had gone from 8.8 to 0.6. So, and that's what she looked like at the end. Another similar case, I'm going to go through it very quickly so I can reach the last one. Similar thing, we extract the teeth, we place the implants, we let her heal, we connect the abutments, we put her in a temporary also for a while. Then we make the permanent bridge, we deliver it, and that's how we send her home. Similar scenario, but this person is only interested in doing the top. Pre-op, side, middle, side, CBCT, planning, surgical guide, extractions and surgery, surgical guide in place. All the implants are in. We give her a removable denture with a soft reline. We all had good stability on those implants, so she wears that at the top. That's what it looks like a few weeks later. The follow-up scan. The soft tissue again 10 weeks later. Temporary bridge this time. So the bridge that she has here is no longer the denture, it's a bridge, but it's made of PMMA. And then we go into design of the frame of the bridge. In this case, it's a bridge, it's not a hybrid. And here we are. That's a finished bridge. Can everybody understand the difference between the bridge and the hybrid? The hybrid looks like the denture, but cemented like a bridge. The bridge is a bridge, almost like tooth to tooth to tooth to tooth. A lot of people get that confused. And the last one is with a two-piece with a screw. So now, you see, things are coming back to what we were used to. We used to do a lot of screw retained. And I like screw retained because they're more serviceable. Again, collapse bite, teeth need to be removed. We place implants. We let them heal. We start doing try-ins, like we were making a denture for him. This is a wax try-in of upper and lower. Get the video and all the aesthetics. We go for uncovery. We do some perio testing. So now, this and Camlog are the only ceramic implants in the world that have the pegs to test the implant stability using the Ostel device. That's amazing. The other ones you would test with the perio test, but this is the most documented and accurate implant stability tool available. And if you go to Zeramex, they can provide you with the pegs and even the machine. Actually, Ostel has become a division of WNH. They're now WNH together. So anyway, the ceramic bridge is made. You can see now we have the abutments there. It's screwed in. And we make him a nice, soft night guard to wear, because that's a lot of hardware over there. And that's how he goes home. So take-home messages. I'm done. Implants are inserted into bone marrow, if you think about it. Not into bone. It goes into marrow. There's cortical bone, there's marrow, and then there's cortical. Bone marrow has immune functions. Something happens in there. When you place the implant in there, something happens. That's what it integrates. Okay. But when you do that, sometimes you can trigger an overexpression of certain inflammatory pathways. And we should have to be aware of those things. That's why we have to be careful of the materials that we use. Because once we put that material in the bone marrow, there's going to be a certain response. So in closing, we at IOCI, we always try to educate people. We do events in many parts of the world, South America, North America, Europe, and our next one is going to be in Toronto at the American Ceramic Society, one of the symposiums. We're going to have a half-day program over there with Dr. Borgonovo from Milan and Dr. Gupta from India. This is the only guy that has documented scientific literature over 13 years on ceramic implants. Nobody has that. Andrea is a very good friend of mine. We go around the world and lecture together. Very credible guy. And there's nobody out there that can come, that has had papers or has a 13-year retrospective analysis of ceramic implants. Nobody. He does. So, thank you for your attention.